This is Dr. Chris Emily McCrory, and today I'm going to be discussing the 2019 ASCCP Guidelines for Abnormal Cervical Cancer Screening. Our learning objectives today are going to be threefold. We're going to describe the rationale for the recent management updates. We're going to use the ASCCP app to determine management for common abnormal cervical cancer screening test results, and ultimately be able to create a management plan for patients with common abnormal cervical cancer screening results. So the first question really is, why did the ASCCP decide to do these guideline updates? Cervical cancer screening guidelines have been updated numerous times over the years. The ASCCP has collaborated with the National Cancer Institute multiple times to really kind of update screening and management guidelines. In 2012, these guidelines included a rather large overhaul that more fully incorporated kind of our new understanding of the role of HPV in cervical cancer development and ultimately how we could utilize that in screening, and really moved us away from annual cervical cancer screening. It was actually the start of a risk-based model. Those deemed to be at a lower risk, such as having normal cytology or negative HPV, for example, could be screened less often than those deemed to be at a higher risk. In 2017, these two groups came together again to update the guidelines to account for a new screening modality, which includes the introduction of HPV alone as a primary screening option in 2015, as well as additional data available on the risks. A shared goal of not having to update these guidelines as frequently also spurred this particular collaboration. So as you can see here, the goals of this collaboration were really simplicity, adaptability, and equal management of equal risk. So ultimately, it was to include incorporating further risk-based management for numerous triage management combos without generating an excessive number of algorithms. Those who are familiar with the previous guidelines may remember those 20-plus page PDFs that included all types of algorithms that could sometimes be a little confusing. Additionally, this new guideline has been designed to be adaptable so that as new screening tests and methods become available, they'll be able to incorporate them better. For example, when primary HPV screening became available in 2015, there was not an easy way to incorporate it into those existing guidelines or those existing algorithms. Going forward, knowing that new technology is always kind of coming down the road, having a guideline that can incorporate it without having to be reinvented becomes quite important. The way to do this comes in the form of equal management of equal risk. This guideline uses the immediate risk as well as the 5-year risk of CIN3 to determine management. If the risk assessment meets the clinical threshold for a specific management, then that is the management. When newer tests become available, we will be able to use the risk of CIN3 from those tests to determine the management without having to change the guidelines. The risk of CIN3 is the important component, not what the specific test results were that got you to that percentage of risk. So this need to simplify and adapt, essentially the National Cancer Institute kind of created their collaboration of epidemiologists and statisticians to compile epidemiologic evidence on the different test performances. And the ASCCP put all of the stakeholders together, including ACOG and the AAFP and more than other 10 organizations who have interest in women's health, to really conduct a consensus of those stakeholders to create guidelines based on the evidence provided by the National Cancer Institute. And that gives us the 2019 risk-based management guidelines. So before getting more fully into the actual guidelines, just a reminder that it is important to know who the guideline applies to. You should do this with all guidelines, not just this one. Does the guideline I'm looking at apply to the person or patient in front of me? This guideline applies to anyone in the United States with a cervix. And always be mindful if your patient has a cervix, because it may not always be obvious. So women, regardless of their sexual activity or sexual orientation, who have a cervix should be getting routine cervical cancer screening. as should transgender men who have a cervix, non-binary or intersex individuals who have a cervix. And then this also applies to individuals who had a cervix but had it removed in the setting of CIN2 or CIN3. And again, this particular guideline is generalized to patient populations in the United States. So the important take-home message of this guideline really is this. It is all about managing risk. The guideline specifically defines the risk of CIN3 as the threshold for determining how we should manage abnormal cervical cancer tests and cancer precursors. I will do a basic review of how the ASCCP and the National Cancer Institute determine the risks, and then we'll do a few examples. So the ASCCP considered the 5 most common scenarios in which you would be looking at cervical cancer screening test results. Each of these scenarios, by their individual nature, affect the predicted risk of your patient. So you can see each of these scenarios incorporates a higher risk profile. So you start with a new abnormal screening result. So this is a patient who came in for routine screening, has not previously had an abnormal screening result, and now has one. The next scenario would be management following a shortened surveillance. So this is an individual who had a previous abnormal screening result that did not warrant colposcopy, but didn't say that they could go, 5 years before their next screening. And now you're looking at that result, and you can see how that is going to be a patient who is likely at a bit of a higher risk than someone who's never previously had an abnormal result before. The next clinical scenario is interpreting a colpo biopsy. So again, looking at the results in that context of this is a patient whose pap smear was sufficiently abnormal to warrant having a colposcopy, and that colposcopy warranted having a biopsy. The next clinical situation is following up post-colposcopy on a patient who did not require any kind of treatment such as cryo or LEEP. And that last clinical scenario is following up post-cryo or post-LEEP. So again, you can see where the risk for the patient increases with each of these different clinical scenarios. Now, depending on your patient's risk based on that clinical scenario, their history, and their actual test results, there are 5 potential management actions that could be incorporated. So routine screening is exactly as it sounds. It's that 5 years before you need to have your next screening. For these particular results, they really are looking at people who are on that 5-year co-testing kind of screening interval. The ASCCP actually considers women under the age of 24 to be kind of a special population anyways. So when we're looking at these routine screening being that 5 years, we're thinking about women who, by nature of their age, are have that preference for 5-year co-testing. The next possible management option is a 3-year surveillance. So this is this idea that the patient is returning for cervical cancer screening in 3 years as opposed to 5 years, which is considered to be shortened in that patient population. Obviously, if you're looking at a patient who is in that kind of 21 to 29 year range, they may only have the 3-year surveillance as their routine screening. The next possible option is the 1-year surveillance. So that's the patient returns for cervical cancer screening in 1 year, which is, again, a shortened interval. The patient could be warranted to go to colposcopy, or the patient goes immediately to LEEP or cryo without having colpo, and that is that expedited treatment. Realistically, there's actually a 6th option, which includes a patient discussion about colposcopy versus expedited treatment when both are acceptable. You may recall from the previous algorithms that there is this kind of option in some clinical scenarios where there are 2 acceptable options, as opposed to sometimes there's an acceptable and a preferred option. So this there are some clinical scenarios where that discussion about which way to go being had with the patient are both acceptable. So for each given clinical scenario, patient history, and test result, there is a calculated risk. So this is where the National Cancer Institute came in with their epidemiologists and statisticians to review what, quite frankly, is an enormous amount of data and devised a risk calculation. So the data came mostly from a longitudinal database from Kaiser Permanente, Northern California. And the reason why this database was used is starting in 2003, Kaiser Permanente implemented a Q3-year co-testing for cervical cancer screening for all of their patients eligible for cervical cancer screening. So they have more than 10 years of data encompassing over approximately 1.5 million patients. Now, to ensure generalizability, they also included additional diverse screening programs, as well as using systematic reviews for some less common conditions. So now that we have those risk calculations, how do we apply it? So really, how do we know what to do and when to do it? So the most important consideration is that the endpoint to be thought of is always the risk of CIN3. So for every clinical scenario, patient history, and test result, the National Cancer Institute identified the percentage risk of CIN3 in kind of two conditions. So you can see here that there is both a look at the immediate risk of CIN3 and a 5-year risk of CIN3. If the immediate risk for CIN3 was equal to or greater than 4%, then we move right on to management as opposed to surveillance. Management is also kind of a 3-tiered branch point. And you can see here on the chart that if the immediate risk is between 4 and 24%, then colposcopy is recommended. If it's between 25 and 59%, expedited treatment or colposcopy is both acceptable, and that's again when you're going to have that discussion with the patient. And then if the risk is 60 to 100%, that expedited treatment is preferred. You're going to be preferred to just bypass colposcopy and go right to LEAP or cryo. If, on the other hand, the immediate risk for CIN3 is less than 4%, we move to these surveillance options. Again, a 3-tiered kind of surveillance options, again, depending on the risk. If the patient's risk is greater or equal to 0.55%, that patient's going to be recommended to return in a year for 1-year repeat testing. Between 0.15 and 0.54%, patient's going to be recommended to return in 3 years, and if that risk is less than 0.15%, return in 5 years. So again, that routine screening. So this is really what the app is ultimately helping us determine. What are those percentages for immediate CIN3 risk, or for that 5-year CIN3 risk for determining management and surveillance intervals and options. So where do I get the percentages? Because of course it's those percentages that are ultimately going to determine your management, treatment, and surveillance. So there are 5 Excel files that you can access from the ASCCP, 1 for each of the clinical scenarios, and you can go there and you can look up the patient history and test results and follow over to the percentage for CIN3. As you can imagine, it's a big clunky Excel file, probably not where you're going to want to be trying to access to get information. But don't worry, there's an app for that. So the ASCCP Management Guidelines, and I understand for an app, this is relatively expensive. This is the same cost as their original app was. It is available on both iOS and Android, and my recommendation, and hopefully I'll be able to explain why I have this recommendation, is that you do get the new app. The old app it's not just an update from the old app, it is an entirely new app, and you're really going to want to invest in that, I believe. So within the app, there are 2 different risk assessments, and you will only see the relevant one for the data that you put in. And I think this was a component that was a little bit confusing when I talked to colleagues who were utilizing the app for the first time. It was not clear that you would only get the risk assessment that was relevant, although thinking on it, that does make sense. So if you put in circumstances that have an immediate risk for CIN3 being less than 4%, you would not see the table here on the left because the risk is less than 4%. And you can see that's where the bar graph ends in that kind of lime green area. Instead, you would see the 5-year surveillance risk for the recommended screening interval, which is, of course, the table over here on the right. So these are the 2 risk assessments that will ultimately be the results that you're seeing, but you will only see the one that is actually relevant for the case that you have put in. So let's do a case. So we have a 27-year-old G1P1 for routine cervical cancer screening. No prior abnormal cytology or HPV results. Her last cervical cancer screening was 3 years ago. She has no concerning symptoms and she has no additional PMH. So important notes to the history. So she's G1P1. She is not currently pregnant. She is here for routine cervical cancer screening. So that's kind of that clinical scenario. If you recall from the 5 potential clinical scenarios, that was one of them. So no prior abnormal results, so definitely routine. Her last screening was 3 years ago, so she has been up to date on her screening. This is not someone who's missed screening. She's asymptomatic, and she has no additional past medical history, so no immunocompromising conditions, no surgeries indicating that she has no cervix, so just things that we're keeping in mind that could have an effect if those components were positive, which are negative for her. So this is going to be screenshots from the actual app. So when you open up the app after it gives you the little guideline note that says, hey, only clinical people should use this, you end up on this kind of management screen where you can put in the clinical situation. So able to identify her age, and again, you see those kind of 5 clinical scenarios that we had talked about before, and then you'll see at the bottom of those 5 clinical scenarios there are 3 special situations. So rarely screened patients, those are your patients who haven't been seen in 10 years, patients who are symptomatic, because again, if a patient is symptomatic, we're not really talking about screening at that point. And then the special situation of immunosuppressed patients. So again, talking about our patients with HIV, patients who are on immunosuppressive medications for transplant or other things along those lines. So just to kind of have an understanding of what that looks like. So in this case, you touch, and so she's 25 to 29. She's here for management of routine screening results, and we would hit next. And that would bring us to the second picture here on the right. So this is asking for her current testing. So for this patient, we're going to see that she's HPV positive and she has ASCCP for her cytology. Now you'll notice on the HPV component that there is positive untyped and positive genotyped. So for most HPV screening tests, and you'll certainly have to look and see what this is for your own institution, they typically actually screen for 12 to 13 different high-risk HPVs, which include HPV 16 and 18, but include several others. So you would get positive if any one of those came back positive. So that would be that untyped. You don't know which one came back positive, but one of them came back positive, as opposed to positive genotype, looking specifically at we genotyped it for 16 or 18 because that has different implications. So underneath the cytology, you'll see that it has this kind of question, does this patient have previous screening test results? So she does, but because they're all normal, you can go ahead and click no. Although if you wanted to put in her previous ones that were normal, you could. But you can see this can come up in those other clinical scenarios, and we'll do an example of one who has had a previous abnormal in a few moments. So then the screen on the left here is just kind of confirming that you were doing co-testing, that this is management of a routine screening result for someone ages 25 to 29, that they had a positive HPV and an abnormal cytology test result with ASCCP. And so then the page on the picture on the right gives you above the recommendation, and the recommendation is colposcopy, which is probably not too abnormal for or unexpected for that particular clinical scenario. So you can see that the risk is greater than or equal to 4%, and in this case the immediate risk for CIN3 is 4.4%. So we see the management recommendation, we don't see the surveillance recommendation, and you can see that it has identified what that immediate risk is and where it falls on that continuum. So not only can you kind of talk to your patient about what the recommendation is, but you can also talk to them about what the specific risk is. So ongoing management. So we've sent her to colposcopy, and once we have those colpo results, we can use the app to decide ongoing management. So in this case, we're again at that first management screen like we were before. You can see we've clicked someone who's 25 to 29 because that's how old she is. But now instead of hitting management of routine screening results, we're going to click evaluation of a colposcopic biopsy. And that's going to bring us to the screen where we can identify those results. Now we're going to say that she had no CIN on this biopsy. We're going to be able to identify the cytology prior to colposcopy, and in which case it was ASCCP. And then you're going to get the screen on the right, which states that you're just confirming that we're evaluating a colposcopic biopsy on someone whose age is 25 to 29, whose previous cytology was ASCCP. And we're going to get the management recommendation of 1 year follow-up, and that there would like there to be HPV. So again, that kind of co-testing. Note we don't have a risk assessment. The patient doesn't have a CIN3 based on the biopsy, so there is no immediate risk for CIN3. I don't know exactly why they didn't put in the risk for surveillance, but as far as I can see, everyone with colposcopy and biopsy gets a 1 year follow-up if treatment was not indicated. So I'm not sure if they just didn't put in specific percentages for that, but that's, just when it comes to the colposcopy follow-up, you may not see as many of those percentages. So she comes back in 1 year for her post-colposcopy surveillance. So again, we take a look at our handy-dandy front screen here, and she's still in that 25 to 29 year range, but now we're here for management of results during post-colposcopy surveillance. Again, she's had her colpo, she didn't need treatment, she was recommended to come back in a year, and she has come back in a year. So going through, again, the different screens. So the first part is going to be identifying her current testing. So now we're going to say that when we did her, for the purposes of this exercise, we're going to say she again has ASCCP and positive untyped HPV. It's going to ask us, does the patient have previous results since her colposcopy? And she does not. This is the first pap smear she's had since her colposcopy. It's going to give us an opportunity to put in her colposcopy results, which were no CIN. And you can just see that I've kind of scrolled up on the screenshots, because in the actual app, it's a scrolling mechanism. So then in that middle window there, you can see, again, colposcopy that she had no CIN, and that the cytology that brought her to colposcopy was ASCCP. So then the last screen here on the right is just, again, confirming that we put in what we meant to put in, age 25 to 29 for management of results during post-colposcopy surveillance, that her current result was positive co-testing with an abnormal cytology of ASCCP. Her previous colposcopy was a biopsy with no CIN, and that the cytology that brought her to that was ASCCP. And so these are the recommendations for that follow-up cytology and HPV. So we've been following this patient for over a year now. She has her next surveillance recommended in 1 year. And again, you see that in this case, instead of having a management percentage that comes up, it's the risk and the surveillance. So her 5-year risk of CIN3 is 6%. So since that's greater than 0.55% but less than 9%, she comes back in 1 year for follow-up. So let's see if we were to take the same patient and see if she has, see what happens with 2 different results. So I just skipped the initial screens and just jumped to that summary confirmation screen, since we've seen all of the kind of initial screens to begin with. So in this case, it was management of results during post-colposcopic surveillance, because again, we're still kind of that post-colposcopy surveillance. And you can see that her current results, we're going to say she was co-tested negative HPV and normal cytology. those results just prior, so 1 year prior to that was that positive HPV and ASCCS, and prior to that was her colposcopy that had no CIN, and then prior to that was her cytology of ASCCS that was kind of the initial bringing forth of all of this. So you can see that you have this much more comprehensive clinical picture because you're able to put in all of these previous results. So on the right side here, you see that the recommendation is 3-year follow-up. So she does not have an immediate risk of CIN3 that is greater than 4, and you know that because you got a surveillance risk instead. Her risk of CIN3 over 5 years is 0.42%, so that puts her in the 3-year return for surveillance follow-up. So she doesn't need to come back next year, but she can't wait the full 5 years. So what if this was the follow-up? So you can see here that I've again skipped all those introductory initial screens and just brought us to the confirmation summary screen. So here, instead of saying that she was negative co-testing HPV and cytology, what if this follow-up result was a positive HPV and ASCCS again? And again, you can kind of see on that left side the different results that she's had over time. In this case, that recommendation would be colposcopy. And again, I'm not entirely sure within the app why there is not a risk assessment percentage, but in this case, certainly the risk appears to be greater than 4% for immediate risk of CIN3. Again, you're seeing that persistent HPV and that persistent ASCCS, so she's recommended to go to colposcopy. So why we can't use the old app? Same results, different history. So you saw a little bit of this in that first example where we kind of saw what 2 different results could be. But what happens if you've got the same results but just different history? So 35-year-old female test results, ASCCS HPV negative. And in the old app, this would have recommended the following. If you popped it into the app, it would say repeat co-testing at 3 years. So let's put that into the new app. So 35-year-old female with ASCCS HPV negative here for routine screening. If we put that in, we get the return in 3 years. The 5-year CIN3 risk is 0.4%. The immediate CIN3 risk is obviously less than 4% because that's why they brought up the surveillance recommendations instead. So, okay, this is the same as the old app. So what if we have a 35-year-old female with ASCCS and HPV negative? So again, we're looking at the exact same results that the previous patient had. But now, instead of the patient coming in for a routine screening, the patient's coming in for follow-up treatment for CIN3. So in that case, if you look at this confirmation screen, again, I didn't put all the screenshots from the all of the individual components, that we're co-testing negative HPV, patient has abnormal cytology of ASCCS, and their previous stuff was treatment with histologic results of CIN3. Now you're looking at a 1-year follow-up. Again, their risk for CIN3 immediately is still less than 4%, but you can see that their 5-year risk for CIN3 is 3.8%. So you can see that that risk for CIN3 is higher in this patient that's coming in for surveillance following treatment, which makes sense, right? So this is where the new app becomes important. The old app is best adapted for going forward, but not looking back. You could, and I certainly did this with patients, you could certainly start with the oldest PAP you had and go forward, but it was not very, user friendly. And additionally, the old app does not have the updated risk assessments that really take that history into account. So for those reasons, it really is important to use the new information in the new app as opposed to using the old app. So just a few quick notes. special populations, so rarely screened patients, immunocompromised patients, pregnant patients, symptomatic, post-hysterectomy, patients under 25 years old, again, are areas that the guidelines are a little bit different. So certainly with the rarely screened, the immunocompromised, and the pregnancy, as well as the symptomatic patients, that kind of gets incorporated into kind of those special populations. As I mentioned, patients under 25 are just in general considered a special population, but that gets incorporated into the app when you identify the age of the patient. And then post-hysterectomy, particularly taking in mind, was it a supracervical versus a complete hysterectomy, and what were the indications for the hysterectomy? Again, because if the patient has a history of CIN 2 or 3, then there is prolonged screening that's necessary even after a total hysterectomy. So practice recommendations and conclusions, really the most important thing is you want to use the new ASCCP risk-based management consensus guidelines when you're trying to identify how to manage abnormal cytology and HPV tests. And as new evaluation tools come out, look for the prediction of CIN3 to be incorporated into those guidelines without a need for new guidelines. Cervical cancer screening, diagnosis, and management of precancer really is longitudinal in nature, so make sure you have your patient's history and plans for follow-up. It's really important to be keeping track of those results because the management really does incorporate kind of longitudinal tests. And then you may want to really consider documenting relevant history and prior management in notes, particularly if it's challenging to annotate test results, or if you're in a practice where there might be somebody else managing that patient down the line, so that it's very clear what results previously the patient had and what was done. We all know that patients don't always have that information readily available, and it's really important. And there are my references. Hopefully this will help you understand why the new app and guidelines came into existence and how to incorporate them into your patient practice.